Today is the first in our series on the urgent response model, followed by the caseload model and the core model. So if you're enjoying today, please let us know what you think. We'll give you a link for some feedback at the end. So please let us know what you think about the session today. And I do hope to see you in one of our sessions on the caseload model or the core model next week. But for now, I'm just going to hand you over to Wendy Rees to talk you through our urgent response model.
Thank you, Sandra, and thanks, Keith, for driving the slide. So if we can have the first slide, please. So I'm going to give you a very quick overview of the urgent response model, which is a really useful demand and capacity tool for teams that provide either community, physical or mental health services, those that really provide a sort of a crisis response or a same day type of response, rapid response type teams, etc. It's really applicable to a range of services, so it's not just designed for those teams. So it could include services that bridge the hospital and community, services providing discharge to assess pathway 1, but it is designed for services that provide a rapid response. So the model itself will actually tell you if you have the right capacity in the right place to ensure that the requests for help can be responded to within the locally expected timescales. What it does, which is different to other demand and capacity models that have been designed, is it does factor in all of those things that are nuanced to the community, which is travelling to and from patients' houses and between bases. And also it will consider the follow-up care of patients within an urgent caseload for around a week, so a short-term follow-up. It will consider the capacity required for that as well. Thank you, Keith. So a little bit about the challenge of modelling in the community. So as a community nurse, I've worked in the community for 20 years. Demand and capacity modelling has not been something that in my clinical time we ever did. We sort of knew what sort of time we needed for patients within our sort of diaries, but actually it was a little bit ad hoc and sometimes quite worrying when we had a really high demand and we had to sort of fit people in where we could. And of course that sometimes creates a wait for some patients as well. So in the community, people think that demand and capacity modelling is difficult because there's quite a lot of variation between the way that services are delivered, but actually that's not the case with this model at all. And the other thing is that around access to information and data, people are often concerned in the community that actually they don't have the data required to run a model of this level, and actually that's quite difficult to get. But actually, even with community services of different models, there generally is a pattern that patients will follow and pathways which are quite common to those services. So generally we have a referral that comes in, a triage of that referral to look at urgency and appropriateness for the service, and then a first assessment, so that's a visit or a remote assessment of the patient. So actually they are very similar patterns regardless of what the service actually looks like. We have actually developed a sort of a starter model, so Matthew on the call today and another colleague, Paul, because we found that when we were talking about the urgent response model, for a lot of community teams, when they're new to this, actually they wanted something a little bit more simple to have a go at first, and we've actually got a model that people can start off with when they're starting their community demand and capacity modelling. Thanks, Keith. So I just want to tell you a little bit about a case study of a team that used the urgent response model. So this was actually a frailty admission avoidance service in Mid and North Hampshire. It was actually a pilot service, so started a couple of years ago, and actually was a pilot service providing a 2-hour response for patients with frailty that were clearly having a crisis in their health or a decompensation of condition, and they would respond very quickly to stabilise and assess and diagnose any ongoing concerns. So run by acute clinical practitioners with some support from a geriatrician as well. So this is a case study around their journey using the demand and capacity model, the urgent response model. Thanks, Keith. So this pilot service providing this frailty response covered one PCN, so approximately 50,000 population. So that's one primary care network. And they ran a 5-day-a-week service, and it was a pilot, so it was funded with temporary money. Oh, sorry, somebody could you just
Richard on my screen.
Hello, could you just go on mute? Thank you. Lovely, thank you. And then they had obviously the pilot was very successful and patients really benefited from the service. They did a very comprehensive evaluation and they were given investment to scale up the service across 4 primary care networks to a fully 7-day commission service, which actually is now called the Urgent Community Response Service. So very similar to people on the call that might be familiar with that model, a similar service to that. They used the urgent response model, so the model we're talking about today, to review their pilot data. So they actually did a retrospective view of the demand they had in and the workforce that they had to actually look at whether or not they'd made the right assumptions for the business case in terms of scaling up. So they used that initially in 2020. And then they used it to understand the impact of the increase in demand. So then they used it in sort of more real life situations where they were scaling up, they had increases across the 4 PCN in terms of patients requiring their support, and they used it to right size their model. So they actually used it while they were recruiting to actually see where the recruitment was best placed, what types of roles were required and how those roles would work across the 7 days. They now use the urgent response model as an operational tool. They actually update it every month to see where they are, and it is designed to be used by the service at operational level as regularly as you feel is appropriate. Thanks, Keith. So this is just a quick screenshot of the model. It's based in Excel, and Keith and Sandra can tell you any technical details around it, but to me it's an Excel. It's very easy to use. And very clever. So this is one of the first stages of the model, and actually this is where the team can configure the pathways that they use for their service, and it then tells the model what actually it's modelling the demand and capacity on. And this does require a little bit of sitting down as a team to talk through what is it that we do and what are the pathways for patients. So an initial conversation is really important before you do any modelling, because it's only really there as a tool to support the work that you're doing. But so this team had 3 pathways, and this model will take up to 10. So what they provide is, they say we provide initial response, which is that first assessment contact, and that's in the patient's home. They provide an initial follow-up, which is generally the next day, and that can be over the phone, but generally in the patient's home. And then they may provide further follow-up for patients across the next week or 2 if they need support ongoing with the treatment. What we can do at this page as well is actually start to tell the model a little bit about actually how do we get to patients. Now the model will only be as good as it can in terms of estimation. It won't know exactly what you're doing, but if you tell the model exactly what a sort of a normal travel might be for you. So for this team, they covered quite a big patch. They estimated a first sort of initial response might need about 25 minutes because they tend to go to base to that new patient and back to base. And then follow-ups might be more clustered, so they might be less in terms of travel. But you're telling the model your best guess around what time you spend getting to patients. And again, in this modelling page, you can then tell the model actually out of the initial responses, how many people get a further follow-up. And for this service, everybody had a further follow-up. It wasn't just a one-off visit. They would generally have 2. And then generally about 75% of the patients would have ongoing support across the next week or so. So again, you're telling the model the sort of behaviours in terms of the pathways within your team. So that's just a very quick overview of some of the inputs for the model. But obviously we have lots of information for you anyway, and the model itself is quite intuitive. What this does is then, when you actually put in the other information into the model, you will actually then get a forecasted view of what the next week's predicted demand and capacity is for your initial response. It will also do the other pathways as well. So you can do sort of, you know, what would it look like for our initial response? What would it look like for our initial follow-up? What would it look like for further follow-up? So you actually can use it to look at all your pathways. It doesn't measure the performance that you might be, a team like this might be expected to deliver, but it will measure it in terms of whether you have the right people at the right time to respond to those patients. So it's not a performance monitoring tool, but it will enable you to look at how you can meet the performance required. And as I said, this team are now using it to monitor their demand as it grows, and also to monitor the capacity in the team as the team develops. They do use it for a bit of assurance to their commissioners, but again, it's owned by the team, and it shouldn't be shared with commissioners. It's an operational tool, but you can use the outputs in any way that you feel appropriate. Thanks, Keith. So if you could just do the other 3 clicks, Keith, because yeah, that's lovely. Thank you very much. So what the model can tell you, it uses your previous demand data. So you can put in up to 3 years data if you wanted to give a really substantial amount of data. But again, if you're a new team just starting, you might have a month's data, and that's absolutely fine. So whatever data you've got, if you can put that into the model itself, it will then forecast, as I said, the next week. Obviously, the more demand data it has, the more it's able to forecast what it thinks might happen. And it works on the available demand data as well. So actually, if you're a team where you only actually measure your referrals in date and time, that's all you need to do for this model. It will be able to intuitively calculate what that might look like with follow-ups, etc., because you set it up to do that. The more information you have, the better, and obviously as accurate as you can, the better. But actually doing this does allow you to have a look at your demand data and actually start to do a little bit work on data quality if you feel it's not absolutely right. It compares the available capacity from the roster and any non-patient time, so things like your lunch breaks, etc. And the latest version will actually incorporate meetings, things like handover, etc. It will then also be able to differentiate between pathways, so different skill sets or different staffing groups that do different pathways as well. And then it will highlight and quantify the gaps for the overall team by individual pathway, or it will highlight the substantial overlap in terms of capacity as well. So it will highlight information for you. Thanks, Keith. So this is the example output from the model itself once you put all the information you need into it. So this provides you a sort of 1-page view. I know it's really tiny, but we'll send things out for you to have a look at. So what this actually tells you, the top graph, you've got a blue line and you've got an orange line. The blue line is your demand, which you've told the model that's your demand. It's forecasting what it will look like next week. So it's giving you the demand by hour of the day and across the 7 days. And for this team especially, this is at one of the later iterations, you can see the demand profile is quite healthy and quite evened out across the week, a little bit less at the weekend, but that's to be expected. But again, that's something you can look at as a team to see, actually, is my demand profile looking relatively even, or have I got some areas I could focus on? The orange is obviously the capacity, and obviously a little bit jagged because of the shift patterns that you have within the teams, but you want to see that they're pretty much in line, which you can see for most days they are. On the heat map itself, there's a lot of greyed areas, and they're the non-service hours, so you can configure the model to support a team across 24 hours if that's what your team does, but you can also use the hours of your service. So for this service it's 8 to 8, so the other hours are greyed out, and you can see a lovely heat map that tells you by day of the week, by hour of the day, what your capacity looks like. Green is obviously really good, amber's a bit tight, and red is clearly a gap. So it gives you a really good view of what's happening across your week. For this team, they found a number of things. They did find a bit of a tea time gap in capacity, and they felt that was due to some of the handover time and also some of the overlap with their 12-hour shifts. And what they've done because of that is they've actually changed some of their shift patterns. So they actually have 5 different shifts now across the 12-hour day, which means they have people coming in at all of the times of the day that they need. Thank you very much, Keith. So just a little bit more about how the team used the model, as we said before. The team set up the model themselves. It's for them to use. They put the pathways in terms of what they provide for patients. They obtain data from their Tableau, which is their repository for their RIO reporting, which has the demand data, so the referral date and time. They also were able to filter out referrals that were declined, so those that were deemed inappropriate. So they only put in the demand for patients that they'd accepted. And then the capacity was configured using their rota. And the way they do this is they have a bit of a standard rota that they use in the model. So a bit like a safer staffing rota or an ideal rota. So they don't change it all the time, but they have the sort of staffing numbers they expect to have on. And they also have a scenario rota where they've actually used it to actually look at where we've got gaps. If we put in another person here, or if we put in another role here, what would that look like? And you can put a number of rotas into the model, real ones and scenario ones, so you can model whatever you feel like at the time. And when we did this initially, the demand and capacity data showed that the further follow-up resource was really sort of almost over. It was over the top. They'd recruited a lot of support workers, and actually they weren't providing the further follow-up as much as they'd required. So there was a sort of a capacity sort of overload. And what they did was that some of that capacity went into the integrated community team for a while. And they realised that due to COVID, because of the additional bridging services that were funded due to COVID, there was quite a lot of domiciliary support in the community at the time, so they didn't need that capacity. But as we know, that's changed. For anybody that's working in the community at the moment, we know that's drastically changed, and actually those staff members have come back into the team now and are supporting patients along that follow-up pathway. But that's just an example of how they use the model in practice. Thanks very much, Keith. And just a little bit of feedback, because obviously when we're testing models with teams, we want to know it's really useful. And they really did like it. They liked the forward view. They were able to have a look and make changes for the next week in terms of staffing. They used it as evidence to inform their changes in skill mix. And actually, when they were recruiting against their business case, where they had received the funding, they actually changed some of the skill mix within the money that they had because of the modelling. And they've seen the impact of the change in demand because with the investment, and that's been really good to see. They've seen dramatic increases in the numbers of patients they're able to support across the 7 days, and that's lovely to see. And again, as I said, they've tested scenarios in different staffing sort of configurations across the pathways, which is really helpful. And I think as services, we're forever having to adapt and tweak what we do, and it's a really good way to actually just check in every now and then to see where you are. And again, they've got a further understanding of actually non-patient facing time, and actually we've used that learning a lot across, especially into the new starter light version. We talk about that quite a lot, but actually we realise that clinical staff come to work, but it doesn't mean they're always available for patients. So it's really good for the team to see the impact of that, and actually what can they do to sort of minimise that to ensure that patients don't wait longer than they should. But there's some little quotes there which hopefully you can see, and it was very positively received. Thanks, Keith. So I'm going to hand over back to Sandra now, just to talk a little about where these models and resources are, but hopefully we can have a conversation if you've got any questions after the presentation. So thanks very much, Keith, and back to you, Sandra.
No, please, nobody tell me I was on mute. I know. Thank you very much, Wendy. Before I tell you about before I tell you where you can find more information, can I just quickly check in with Keith and then Matthew? Keith, anything else you would like to add to what Wendy described?
Yeah, I think Wendy's just given a really lovely explanation and example of how you can use these models in a real life scenario. And I think and I guess I'm allowed to say this because I'm the models person. It's just a worksheet, actually, at the end of the day. The really important thing about this that comes out is a deeper understanding of the service that's held by the service. So it's organizational knowledge held within the organization, and it's so important because the number of times we've seen in the past where it might be something that's brought in externally and then leaves with the person who, or the organization, once they've finished their time kind of doing a bit of work. The number of times we get a lovely report that's commissioned, but nothing happens from it. This is a great example of actually going through the modeling process and learning about your service as you go through it, and then applying that learning to improving the service. And I think that's a really key bit here about what this brings as extra value to how you're managing your service. So in addition to the quantifying the numbers, it's also that understanding, which is a really important part of the improvement process that this brings to the table. Matthew, I don't know if there's anything you want to throw into the mix with that.
Oh, thanks, Keith. No, I think the only things I maybe would add, it follows on from something that Wendy mentioned earlier, really, and the slide with the impact bubbles on, that the model obviously gives you some of the evidence to support your decision making, but it's the conversations you have as part of the scoping and as part of the process that you're working through to collect the data, to scope how you're going to populate the model around your service, to draw out really the way the service works, that are probably the really important parts, because if you've spent the time focusing on that initial work, then that stands you in really good stead then working through the model. And I know, having worked with Wendy with a couple of other community services, that actually giving people the opportunity to get together either face to face or more often than not now virtually, it's taking that bit of time up front to understand how the service works, to explore any of the things that are maybe known blockages or difficulties with the way the service works. That's really important, and some of those conversations have been so enlightening. Sometimes it's just challenging the way things are done because they've always been done that way, and you're giving people the opportunity to just take a step back, to work through some of those things. And I think that's really important to bear in mind, that it's not just a data exercise.
Thank you very much, Matthew. So the purpose of the session today was just to give you a quick overview of how the urgent response model works. If you would like to have a look at the urgent response model, or you would like to look at a detailed walkthrough, there's a link for you. On our Future NHS website, you also have a number of case studies focusing on different items. A very large case study talking you through some of the steps in terms of what to do before the modelling, what to do with the modelling outputs, the learning, and what happens next. So do have a look if you've got a moment. Thank you very much.